Welcome to the NAMI Radio Hour, brought to you by the National Alliance on Mental Illness, or NAMI, Tennessee, a broadcast that explores the world of mental illness and its impact on the family, society, and the individual. We come your way live from the studios of Radio Free Nashville each Wednesday from 10 to 11 a.m. Central Time. It is our hope that you will be encouraged, enlightened, and maybe even entertained from the stories of our guests. The NAMI Radio Hour is a production of NAMI Tennessee. To contact the show, send an email to info@namitn.org. And now, here's your host, NAMI Tennessee Executive Director, Jeff Layden.
Good morning. Thank you, as always, Vic Moore, for the wonderful intro for the NAMI Radio Hour. We are live in the studio today on a crisp March morning in Nashville. You're listening to WRFN LP in Pasco. It is Radio Free Nashville. And you can hear this show over the air at 107.1 or 103.7 on your FM dial if you're in or about Nashville, or online at www.radiofreenashville.org. Our guest today is Mary-Linden Salter, who is here in the studio. Good morning, Mary.
Good morning. How you doing, Jeff?
Well, I'm here.
Aren't we all?
That's always a good thing. Got to wave to the horses next door. I thought it was time to get warm, so I'm less excited about that. I went out the door and it was sunny, and that's good, but chilly, so hang on. But on the road up here, I did see, I don't really know my trees, but I saw a tree full of pink flowers just busting out, and there's daffodils across the street, so there's signs of renewal coming, so that's good.
Always good, yes.
We are here to talk about Day on the Hill, but specifically what are we calling it? I've seen Mental Health Day on the Hill, but it's really broader because it's addiction and mental health. So Behavioral Health Care Day on the Hill?
I've heard it called Behavioral Health Day on the Hill. Early on in the days of the coalition, they just named it after the coalition. So it's the Tennessee Coalition for Mental Health and Substance Abuse Services Day on the Hill, and that's way too long. So now I think it's the Behavioral Health Day on the Hill.
There, for those less familiar, there's a whole bunch of days on the Hill, and what that's about is that groups that care about a particular issue, be it education or parks or roads or our mental health and substance abuse treatment system, we visit our legislators, our state legislators on the Hill at Legislative Plaza in an effort to educate and influence the legislators to support good, effective policy, in this case related to mental health and addiction services. Is that pretty much accurate?
Mental health, addiction, and more broadly, anything that supports recovery. So, vocational rehab services, recovery supports, recovery homes have been broadly, I think, addressed in past and current.
Your time machine has taken you.
I wish, yeah.
Who's going to win the election if you have the time machine? Is Trump going to hang on or not?
Hang on to what would be the question?
The momentum. Before we get into the coalition itself, let's start at a real basic place. And I forgot to really ask about your background, but let's start at this other basic place. What does the state have to do with mental health and addiction, and why visit legislators at all? Where does the state come into this?
Well, in this state, there are federal, for the most part, SAMHSA block grants that fund a lot of mental health and addiction services, in addition to Tennessee's Medicaid program, which is TennCare. A lot of the state funding got put into the coffers of the TennCare program in order to fully fund, Medicaid. But there are some federal block grant monies that still are administered by the Department of Mental Health and Substance Abuse Services. And those fund a lot of services for people who don't qualify for TennCare, who are perhaps indigent or lack other resources. So the department administers some direct funding for services as well as TennCare.
Okay. I'm going to take you back even a step before that. Some people have insurance, and if they have a mental health issue or substance abuse issue, they call the number on the back of their card. But then there's a lot of other people that can't really afford private health insurance. So it can cost a lot of money to the state and the taxpayers of the state, let alone the misery and difficulty for that individual and or their family if they have untreated alcohol and drug abuse. And then we have a lot of people, at least what I've been led to believe, which I do believe, that a lot of people end up in our jails, homeless, or in our emergency rooms, where if there was treatment for mental health and substance abuse, instead what we have is a taxpayer. So our society pays a huge cost for untreated mental health and substance abuse, and then the state, I would say, considers itself, would it be fair to say, the provider of last resort, whether through funding or through service delivery?
Yes, provider of last resort, and commonly referred to as the safety net, I think, for a lot of people.
It's a more positive term.
Yes, for people. The department even has a special program for those in need of mental health services who don't qualify for TennCare. That is literally called the safety net. But there is, I think, the more generic term safety net would also apply to the broader funding you're talking about. There are some services that can be accessed through various state-funded providers, and there is a way to find out about how to locate those providers. If you'll allow me to do a little plug, TAADAS operates the Tennessee Red Line, and that number can give you access to information about state-funded treatment providers that can help you locate programs all over the state. Those would be mental health, addiction, and whatever. That number is 1-800-889-9789.
Well, thank you. And before we go more to the coalition and what we're doing this year, you've brought up the topic of TAADAS, which you're the executive director. Tell us a little bit about TAADAS and what you do there.
Well, TAADAS got its start as an association of treatment providers for addiction. And actually, we have our 40th anniversary this year, so they started in 1976. And over time, that coalition has grown a bit. In the last few years, since I've been the executive director, we've broadened our membership base even further to include other state-funded recovery service providers, which covers a lot broader base of recovery service entities. That can be recovery homes, peer support kinds of entities. We also welcome recovery courts and prevention coalitions to our membership. So we have and it varies sometimes from month to month, but anywhere from 60 to 70 different providers who are state funded for the most part. But we also now welcome private providers who are part of the service delivery system into that network. So we have a broad coalition of people who are interested in advocating for the service needs for people in Tennessee who have addiction issues, and we take that very seriously. We have certainly always done policy work, but I think we've really energized that broader group of people to be more engaged in policy work and advocacy at the state level in particular. And so we are working really hard this year on our own day on the Hill on advocacy issues. But
which is when?
It's actually already passed.
No.
But we also,
maybe next year.
as part of the coalition, we really advocate for many of those same issues, and it's really a great thing to be part of such a broad coalition as well, that not only endorse our advocacy issues, but we can work together to really fully fund a system of care and a system of resources that will adequately meet everyone's needs.
Mm-hmm. So NAMI does some of its own advocacy as well. So we're working this year to highlight the need for criminal justice reform and not so many people with mental illness or addiction going to jail, but going to treatment instead where possible. But the coalition, on the other hand, is a group of, over 30 organizations, and we have hammered out some common positions that we advocate for together collectively.
Mm-hmm. Yes, and I can highlight some of those, actually. A couple of them are near and dear to my heart. The Coalition for Mental Health and Substance Abuse Services is advocating for a budget amendment that would include $30 million of treatment funding for substance abuse treatment. And $30 million would begin to meet the need for the substance abuse treatment needs that are unaddressed. But let me also say that there is a mitigating factor here. Currently, this state spends a lot of money on jail diversions and jail sentencing for people who have substance abuse issues. We spend a lot of money dealing with children's services issues, school-based issues, employment issues for people who have chronic substance abuse conditions, and we think that this is a better way to focus those funds and therefore take unneeded spending, if you will, out of some of those other service delivery systems. We all know who are in this field that you get a great return for your investment dollar when you invest in treatment, and long-term studies over many years have endorsed like a 7-to-1 return. For every dollar that you spend, you get $7 back in productivity and in people and resources that are more effectively, utilized within our state. So it's an investment worth making.
Well, treatment pays for itself, yes, you say many times over, which can be difficult for some people if they've tried to quit over and over, or family members, and they've promised before and you see relapse. But there's other people that if they seriously work a program, many people recover.
Mm-hmm. Yeah, I think it's important to understand that treatment funding and funding treatment comes out of a deeper understanding now that addiction is a disease. Addiction changes brain chemistry. Your ability to just stop using is affected. I think there's still a lot of people who believe that it's an issue of willpower or an issue of some kind of a personality flaw. We now know more about how many of the chemicals that people ingest affect their brain chemistry and literally alter some of the ability of the brain to deal with chemicals in their body and the addiction symptoms that happen. So when it can take up to a year of sobriety for a person's brain to fully recover. And even then, there are deeply held what's called neural pathways in your brain that often take you right back to addiction. Those neural pathways never go away. You can form new ones, more healthy ones that lead you to better responses. But relapse, as you just called it, is still something that it lurks in people's brains because of how your brain is altered by taking those substances.
I'm thinking of which way to go here, and I'll just start with this. I've been amazed how it seems more socially acceptable to say I've had a alcohol or drug problem than to say that I've had a mental health problem. But before we go into that, I want to stick with the 30 million. Mm-hmm. I lived in New Hampshire before I came to Tennessee, And I never heard the word heroin mentioned that I can recall. And now, almost 3 years later, when we had the presidential primaries, they're talking about the heroin epidemic in New Hampshire, and it's trickling into the campaign.
Mm-hmm.
So now I've heard more recently about heroin abuse in Tennessee as well, and the state was working on reducing prescription abuse, and they had the program where they were trying to educate that and come up with laws about the precursors for meth and limits and that. So now, evidently, heroin abuse is increasing. Is that correct in Tennessee?
It is increasing, and I love that you asked. Let me address some of that. And many of the laws that have been recently enacted that put limitations on access to chemicals and things that allow for meth production, or the opioid prescription database that requires doctor to monitor their prescription practices, have really worked wonders in limiting access to certain substances. However, that doesn't make the addiction go away. And I think what we're seeing is the result of untreated addiction. When your access to opioids, for example, is reduced, and you still have that craving and that addiction, you're going to turn to a substance that is more readily available. And in many cases, that's heroin. In this state, we have what I've heard the Tennessee Bureau of Investigation characterize as a huge drug cartel issue. They're bringing in very low-cost heroin because they know that people are facing, limits to their opioid prescriptions. They're literally marketing it as a low-cost, substitute and hooking people. And then once you're hooked, they can do everything from raise the price to do whatever. So people are desperate for some kind of relief. We at TAADAS staff the Tennessee Red Line. It's a 24/7 hotline that I just gave you the number about for addiction treatment referrals. And we get calls from people every day who are desperately seeking an alternative. But we hang up the phone knowing that many of them will be on waiting lists all over the state and will still be using in order to try to manage their symptoms until they find a program.
So is much of this $30 million for treatment for those addicted to heroin, or is it just general treatment, whatever the substance happens to be, alcohol or meth or whatever?
The budget amendment, as I understand it, is not specific to any particular substance. It would be broadly funding addiction treatment, which would be cover treatment for many different substances, from alcohol to heroin to meth to opioids. Many people use a wider range of those substances because, as I just pointed out, you often find yourself using what's available in order to manage your cravings and symptoms. So we want a broadly funded treatment system to be able to meet all of those needs.
Mm-hmm. Is the state funding residential treatment as well, or is everything outpatient?
No, the state indigent treatment funding does pay for residential as well as outpatient treatment and detox.
Mm-hmm.
Mm-hmm.
Okay. So one piece in the platform for the Mental Health and Substance Abuse Coalition is the $30 million to increase funding for our substance abuse recovery services. What else is in the list?
Well, one of the other issues that has been a need over many years and has been advocated over many years, continues to be a need, and that is some crisis services for both adults and children. But in particular, there's a request for $6 million for a children's crisis services system, and another roughly $400,000 for an adult to augment the existing adult crisis service system. For children, this is especially critical because there's been a shift in how to treat children in this state, in that a state-funded inpatient facility was closed down, and the state went to a system that tried to utilize existing private beds for services. But unfortunately, our state population is growing. In particular, I think it's evident here in Nashville. The population of Nashville is exploding. We've had a lot more demand for services at a time when those beds have been reduced, and we're seeing children sent to programs all over, including out-of-state programs, in order to be able to find capacity to treat many kids.
Which would make it real hard for the family to be involved in the care.
Very much. It's problematic whenever a child is taken out of the home to engage the family, but when distances are involved, it makes it even more difficult. What this funding is hoping to accomplish is a mechanism for children to go into a crisis stabilization unit, and that the $4 million would fund such a unit. That would allow for not an inpatient stay, but a crisis respite type of stay where the child could be stabilized and then immediately sent back home, promoting family unity and promoting family in-home services that will keep that unit intact and actually have more potential to work on issues that are problematic for the family system. Children exist in systems and in families, and typically that's where the solutions need to be found.
Mm-hmm. For those not real familiar with this crisis piece, I'll just share that earlier in my career, I worked as what was called a emergency services worker or a crisis counselor. And we had a facility that had some locks on some of the doors, and there was a guard there, and there was a psychiatrist, and there was a nurse, and there was crisis workers. And people would come in, sometimes brought by the police. Now, when you don't have a crisis service like that, if somebody appears to be, let's just say, not safe enough to just leave them at home, that they may be unpredictable with their behavior, and they go to a hospital emergency room, the choice is let them go or admit them. But the ER, what they have to do is come up with a disposition, what to do with the case. They're not going to be doing a lot of mental health or addiction treatment, talking about all the stressors and all the players and doing therapy in an emergency room. Maybe there's a shot of tranquilizer if someone's in a panic attack, but typically you assess, you do something quick, and then you have to have a disposition, meaning discharge with follow-up or admit. Well, when you have a crisis service, I think you put it very well. There's time in a way that's less expensive than a hospital and less in putting somebody in an institution to kind of figure out really what's going on and how we could possibly intervene.
Yes. There's some crisis management type therapeutic models out there that can be utilized and to really help stabilize the situation so that longer term treatment planning can occur. And typically people react in a crisis, but in a day, no more than 3 days, things have taken a different turn, and people are more able to resolve issues of crisis and utilizing that window of opportunity and then returning the child to the home so that there's no long-term effects of that crisis, I think are critical to help families heal.
Mm-hmm. Well, when you talk about children, my work was more with adults, but with the child, I think that there's probably a greater possibility for more unintended negative effects when you put a child into a hospital, and there's times when that needs to happen. And when I say hospital, I'm referring now to a psychiatric hospital. It's a last resort. It's better as a last resort than a treatment of choice.
And I think that people while putting a child in a hospital is seen as a benevolent and helpful thing, you also need to realize that it's potentially traumatic. So lessening any potential issue of trauma for the child and the family helps to make sure that crisis is, like I said, less has less long-term effects in the family.
Mm-hmm.
We always want to be helpful. We don't want to hurt. There's sometimes that fine line when trying to provide emergency treatment.
Mm-hmm. The other piece with mobile crisis, which is where some of this money I think would go, is sometimes people are frustrated with how long they have to wait to have somebody, a mobile crisis team, come to evaluate if there's a crisis, whether they're coming to an emergency room or therapist's office. And I don't think they've gotten any increases in state funding for quite a while, but the number of people that need the services are more. And if more people knew about mobile crisis, the number might go up again. And if we can prevent a suicide or some other dangerous violent act through the use of mobile crisis. So this again is state funded, but the mobile crisis, or all the crisis stabilization, it's contracted out. So the state pays for it with various revenue sources that they can get, and contract with, like in Davidson County, it's mental health co-op. Is that correct?
That is correct. For both children and adults here in Davidson County. It's hard to differentiate mobile crisis from a crisis stabilization unit or from many of the other kind of safety net providers, community mental health centers and addiction providers who are state funded and really form a network of services that we try to make available to everyone, certainly in crisis or in urgent need of care. But right now we have what I think is a serious gap in the system by not having a crisis stabilization unit for children that will help everyone to serve children better.
So this $6 million, would this fund just one system, or would there be more than one around the state?
Well, I think people are relatively open to discussing that. The intention with the $6 million was to fund one particular program. And I know that may not seem optimal to people, but it is a way to establish a service delivery piece in the system that's lacking, and hopefully we can build on that.
Mm-hmm. Well, I might say it's expensive to build a system of care, and to have something like this sounds really important, but the cost to not have it
is much greater. We're spending a lot of money to send children to out-of-state programs, and like I said, those are inpatient programs. They often take much longer for a child to be able to stabilize and to work on treatment issues, and in a setting that's not home-like and not very conducive to resolving issues of daily living. So it can be a long-term treatment option that has very short-term effects, and being able, like I said, to manage a crisis and then manage that long-term treatment issue in the child's home and with their family unit wherever possible has a better chance of longer-term good outcomes.
Mm-hmm. So then there was a couple other pieces in the request from the Mental Health Coalition for Day on the Hill.
There are. There's a couple others that I'd love to talk about, and then maybe talk about the fetal assault law too. But one of the things that was requested is the elimination of a 1% rate cut for providers that was put into place for TennCare programs, and it was implemented last year as a way to deal with some budget issues. However, this year we have a rainy day fund that seems to be fully funded, and we can, I think, relook at that and try to fully fund a system of care in a way that actually allows providers to stay in business and to promote new kinds of treatment rather than cutting back services and cutting back their rate of pay. As you pointed out, there hasn't been a rate increase at least for the state-funded system, in nearly 20 years. And inflation has certainly increased quite a bit in the last 20 years. So we're able to provide, in some cases, less services with the same amount of money, to cut back the provider rates at a time when we need to expand our service delivery system, I think is inappropriate. And I'm glad that the coalition is taking a look at that issue and trying to help promote a better, more fully funded system of care.
Mm-hmm. I would think that a rate cut would mean a lower salary, which means more turnover.
Mm-hmm.
A lot of folks back when I started, including myself, we'd come out of school, we'd work in a community mental health center, get some experience, and move on to something that paid better. Is that still common?
I think it's still very common. I worked at a community mental health center myself for several years, and was in a position to be a clinical supervisor for social work students in particular. And so we would see, students coming in, and certainly masters prepared but unlicensed folks that I would supervise. And very typically they would work at a community mental health center, gain their licensure, and might work for a little while beyond that, but typically would use that as a segue to move on to a different clinical situation. Now, I don't begrudge anybody the opportunity to get good clinical supervision in a setting that is challenging and certainly very worthwhile towards being able to understand, mental health and substance abuse issues. But it becomes an issue for stability for those community mental health centers and addiction programs, and I think doesn't allow for a growth of staff that can really help sustain and maintain programs at their highest level. And I say that knowing that there are many quality programs out there, but I think many of those programs would love to have a stability of staff that would help them maintain some program integrity.
Mm-hmm. I think it's odd that a master's in social work, which is what I have earned, it has the lowest pay, I believe, of any master's degree that you can get, including art history or foreign literature or really anything else. And when you compare the pay rates for people that work with folks with mental illness and addiction compared to nurses in a hospital or other folks that are working in just primary healthcare systems, we talk about stigma about mental illness, and maybe with addiction as well. I hear more about talking about mental illness. Not sure if there's more. I just hear more. But when you look at these, we've built separate systems to treat addiction and mental illness, and the pay rates are not at all in the same ballpark.
Yeah, I'm a licensed clinical social worker myself, so I recognize the pay disparity issues, and in social work, we are in a field where a master's is really almost a prerequisite to being able to work in the field, and yet the pay certainly is not commensurate with the level of experience and debt that we incur to be able to do so. But if I can take a brief segue, I was recently on the Hill at Legislative Plaza dealing with a counselor's bill, and it became very clear that many of the representatives on the committee that was reviewing it really had very little understanding of what it took to become a counselor, of the education piece, of some of the standards and ethics that are required of a person to commit to in order to be a good counselor, or, as you said, social worker.
Internship and supervision in addition to the degree.
As they were reviewing a bill having to do with some ethics components for counselors, it really became something where I'm hoping we helped educate them about the amount of commitment that it takes to become a counselor or a therapist.
We've reached the halfway point, or actually a little bit beyond that, but you are listening to the NAMI Radio Hour with guest Mary-Linden Salter, who is the Executive Director of TAADAS and a member of the Behavioral Healthcare Coalition in Tennessee, and we'll be back in just a moment. We are back live on the NAMI Radio Hour. I'm Jeff Flayden. I'm the Executive Director of NAMI Tennessee. And I'm visiting today with Mary-Linden Salter, who wears a few hats. She's a licensed clinical social worker in the state of Tennessee. She's the Executive Director of TAADAS, which is
the Tennessee Association of Alcohol, Drug, and Other Addiction Services.
I was afraid to try it because I might not get it right. And she's here today also as a member of the Behavioral Healthcare Coalition, where we have an upcoming Day on the Hill opportunity for citizens to meet with legislators to get educated and then visit legislators. And we are advocating for some issues, which we'll get at in a second. Mm-hmm. But I forgot to mention, if you'd like to come to Day on the Hill, didn't mention this in the first half, you need to sign up. And the easiest way I know of to sign up is to go to the NAMI Tennessee webpage, www.namitn.org, or just Google NAMI Tennessee. And right on the front page, there's a link to go to Eventbrite, and you can sign up. It is free, but it will fill out. It will fill up. It'll sell out, I guess you could call that. All the space will get utilized. There's about 600 lunches that will be purchased, or maybe 500, and we'd like you to have one if you come, and a place to sit. So you need to register. If you could do that, that would be great. Mm-hmm. And
can I interject some schedule too?
Sure.
The breakfast for that day, that on March 15th, starts at 8:30 in the morning.
I left breakfast out. There's breakfast and lunch.
There's breakfast and lunch, and then
lox and
the
bagels?
actual. I only wish. I don't know, but I'm sure I'm not part of the program committee, so I couldn't tell you exactly what they're ordering. But the program will start at 9:30. Many Tennessee leaders have been invited to attend, including Speaker of the House Beth Harwell, Lieutenant Governor Ron Ramsey, and many others. So obviously their attendance is usually subject to their schedule on that day, but we're really hoping to get several Tennessee leaders from the legislature to attend and address the group. At 11 o'clock that morning, there's going to be a panel of folks that have been affected by several of the issues that we're talking about. One of the panelists is going to be, I believe, a family member of a child who had a crisis, and we'll talk about their experiences with the system of care. And then there's going to be three ladies on the panel talking about their experiences with the fetal assault law, which is another thing that the coalition is actually asking for that law to sunset, to effectively go away, because we're not seeing any good impact from that law.
So, what is the fetal assault? What is the fetal assault law?
The fetal assault law was enacted 2 years ago, and when it was enacted, it was given a 2-year time frame as almost like a study period to see the impact of the law, and that was done. In my opinion, because I think people thought it was controversial then and wanted to make sure that what they were doing was appropriate. But the law basically allows for a woman to be charged with a misdemeanor assault if, after giving birth to a child, that child tests positive for what's called neonatal abstinence syndrome, and that's a very long title for basically that the child has opioids in their system at birth and is exhibiting symptoms that are very much like withdrawal. The baby with NAS is typically in a NICU, a neonatal intensive care unit, in order to manage those symptoms. But the law and allowed for a woman to be charged with assault unless as a defense she could prove that she had been in treatment during while pregnant, and actually post-pregnant as well, I believe. But anyway, the problems that we saw with that initially have really proven to be true. As soon as women heard about the law, on the Tennessee Red Line, for example, we had a rush of callers concerned about it. I know there were women who literally left treatment concerned that they would be convicted of assault because treatment for opioid addiction in particular requires that a woman, I shouldn't say requires, but the best practice that's currently been endorsed by SAMHSA is some kind of medication-assisted treatment with either methadone or Suboxone. And what that medication is given to a woman during pregnancy in order to sustain the pregnancy, basically, to make sure that her withdrawal from an opioid does not start early labor of any kind, which would put the baby at risk. So the best way to maintain the health and safety of that baby is to maintain the mother on a medication at safe levels through her pregnancy, and then begin an actual withdrawal to abstinence after she delivers. So there are many babies who are testing positive for NAS at this point, who are being born of mothers who are in medication-assisted treatment programs. The recent statistics at the end of 2015 showed that up to 80% of women who had babies born with NAS were actually taking medications as prescribed in whole or in part.
Are these mothers being arrested?
There have been several arrests around the state. There's rather conflicting data about how many. Part of the problem with tracking the data is that it's an assault charge, and there's no earmark on that charge. It says the assault charge was based on an NAS birth. So tracking statistics about the number of assaults for this particular reason has been difficult to obtain. There's some anecdotal data from different district attorneys around the state. We're of the belief that there's been anywhere from 90 to 130 arrests of women across the state. I actually met with a woman who's going to be one of the panelists at our Day on the Hill. Her name is Brittany Hudson, and she was arrested under this law and had actually sought treatment while pregnant, was not able to find it because there are very few treatment centers that will treat pregnant women. If you can imagine, it's pretty much of a specialty treatment amongst addiction providers. And because she was unable to find treatment, she gave birth to a baby who did have symptoms of NAS. She actually sought treatment after delivery and was denied authorization for treatment by her managed care company, by her insurance. So
denied because she didn't need treatment?
My understanding is because they didn't want to authorize that particular level of care, which would have been residential treatment. But that's something that you can ask Brittany about on Day of the Hill.
Okay.
I do think that, after she sought treatment and where she went to, I believe it was a doctor who called DCS at that point. DCS got involved, and then she was arrested under this law after having sought treatment on multiple occasions.
So she went seeking treatment and ends up getting arrested.
Correct.
Amazing. Now, I thought that this law also covered if a woman's pregnant and she has a positive drug test. Was that also an arrestable offense? That
was not the intent of the statute, as I understand it. However, there have been several women who were arrested in that circumstance. And that's, I believe, a misuse of the law, and is something that we've gathered some data on to try to help legislators understand that the misuse of the law is very problematic as well.
So if you missed the first half of the show, we talked about a request for $30 million to increase substance abuse and recovery services, and $6.4 million for
crisis services,
adolescent and adult crisis, and then the neonatal piece. But there was at least one more.
We actually eliminating the 1% rate reduction for providers in the TennCare program. And I would like to point out that the $30 million to fund substance abuse treatment in Tennessee would greatly help us provide treatment for women who need treatment while they're pregnant. And those service providers right now are very minimal. TAADAS wrote a white paper addressing this issue that was distributed in November. And at that time, we had identified 11 providers in the state who actually provided treatment to pregnant women. That's 11 out of the, I think it's 24 licensed residential detox programs in the state of Tennessee. So less than half will actually accept pregnant drug-using women. And of those 11, just over 100 beds were available on any given day for women. Since that time, an additional program has opened up, so now we have 12. And an additional, if my memory is right, I know it's less than 10 beds at that program. So we don't have a huge capacity, and we have thousands of women every year who are at risk of giving birth to NAS babies because of the opioids that they take. So we really need to provide better access to treatment in order to be able to address these issues. We at TAADAS have really taken a strong position that we think access to treatment is the issue that needs to be funded, and that we need to provide treatment and not jail.
Mm-hmm. And then there was a piece about employment.
There was around a vocational rehabilitation type service, and I have to admit I'm not very well schooled on that one. That's a program that I think is available to people through a vocational rehab type program that's implemented at a community mental health setting. So I would have to defer on that one.
I know a bit about it, but I don't remember what was how much was being asked for. The program's called IPS, and it is a program that was developed at Dartmouth College that's being implemented throughout the country, and it's part of a research study. To do it, you have to participate in the study, which measures the effectiveness if money spent on helping people with mental illness get back to work helps.
Yes.
And the results have been really, really strong. And what it's about is a combination of vocational rehab and mental health case management with job coaching. And we've got, I don't know all the locations, but I know it's in Nashville at Park Center, and it's in Knoxville at, I'm not going to try to...
Isn't it Helen Ross McNabb?
Yes.
Yes.
And there's other sites, and we wanted to expand it more because when you look at the number of people with mental illness that are on disability, it's really large. In fact, mental illness, I believe, is the highest cause for disability and people getting Social Security disability, in which case they're receiving public money rather than working. But what we've learned with IPS is you don't have to wait until all symptoms are better before you can work. But in fact, work helps people to recover. And that's probably true of substance abuse as well. So it's an effort to get people working and to pay for a team. It's a team approach to help get folks with a mental illness diagnosis or a disability related to mental illness back into the workforce. And it's been very successful, not just across the country, but across the world. And we would like to see an expansion of that. So we think that that's very important because many, many people that have mental illness would rather work. And Social Security just does not pay that much. So, yes, you get a check, but it's a tough life. So it's just good all the way around. And
work is more affirming, and it's more conducive towards skills that actually help people recover.
So what else is happening? So we have talking points that hopefully all coalition members will share and
there is one more program that the coalition endorsed. That
I left one out.
Yes, I'm sorry. But and this was one that it was really an endorsement of something that the governor added to his budget, and that is to support almost a $1.3 million addition to the budget that would fund veterans and recovery courts in the state of Tennessee. That was done at the recommendation, I think, of Commissioner Varney at the Department of Mental Health and Substance Abuse Services, and it's certainly one that TAADAS endorses, and we're happy that the coalition endorsed that budget addition of the governor as well. That will have to be part of the budget amendment package, however, so it does need our support in order for it to be fully funded. I think it's important to fund those courts for several reasons. But first, because I'm on, the fetal assault bill, already, I'll say that recovery courts are one of the chief mechanisms under which women can get access to treatment who are already in the court system. That does happen occasionally. We want to make sure that women have access to appropriate treatment, certainly if they find themselves in that situation. But for veterans and other folks in need of recovery support, this can be a way for them to address an issue that they may have wanted to address over a long period of time. Many of the charges related to that would get them in a recovery court are things like, having paraphernalia related to drug use, possession, and sales, which, while I certainly don't endorse that, at the same time they're symptoms of a larger condition, which is the addiction itself, which really needs to be addressed and addressed in a way that can help them achieve long-term recovery.
I think this would be a good time for me to mention that NAMI Tennessee is also seeking a $25,000, or we deal with smaller numbers, $25,000 budget amendment for the NAMI Homefront class, which is a peer-taught class where family members of veterans receive education and support if they're living with a veteran with mental illness, in hopes to keep the support system and the home intact and support recovery that way. Much as we do with our other programs. But this one is taught by folks that are caregivers of a loved one with mental illness. So that's called NAMI Homefront. We only have, believe it or not, just 4 minutes or so left. So if you want to come today on the Hill, you need to register. And do you have registration on your website too, or how are you telling people?
We do. We have it on our TAADAS.org website. We've certainly sent out the registration information to our membership and have it posted. But as Jeff said, we're expecting as many as 600 people. We've certainly have had 400 to 600 people there for the last few years. It's a group of people that join together to learn more about all of these issues. We send you out, to meet your legislators, having been fully informed about the impact of all of these issues. We give you, sheets of paper with talking points on it. We have an opportunity to hear discussions, and like I just talked about, the panelists that address these issues. We'll have a chance to network with people at your table or at the event to ask questions about the issues. So no one should leave that morning's experience feeling uninformed about what they're being asked to address. I think you'll have every opportunity to feel like you are in the know and able to endorse these issues with confidence and address them with a legislator.
I think that pardon me, that's a really great conclusion to Down the Hill. We
need to give a shout out, though, I think, to Tom Starling and at Mental Health America, because he has really been the chief instigator and coordinator for this event, and I really want to thank him for his leadership at the coalition. I think he's done a great job.
Tom's done an excellent job, and since you've brought up the coalition, let me also mention that there is openness to other organizations joining the Mental Health and Substance Abuse Coalition, and I guess get your information to me and I'll pass it on to Tom Starling, and you can reach me at info@namitn.org, info@namitn.org, or just call Mental Health America of Middle Tennessee, ask for Tom Starling. But I know that there's been an effort, particularly in East and West Tennessee, to get additional organizations to come in, and coalitions are one of the ways that we have our voice heard, and we've been effective in trying to support existing mental health and substance abuse services, but this year we're hoping to actually expand some. As Mary-Linden mentioned earlier, there's a lot of excess money where tax dollars have been raised in excess of what's been spent, and we would like some of those services to be reinvested back into the state to be spent for caring for people, which will help them, help their lives, help their families, and also help the overall climate of life in Tennessee. So there's that, and just to stay updated on who's going to be on this show and things like the advocacy training that we did last night and upcoming Mental Health Month activities, which will be in May. Sign up for the NAMI Tennessee e-news. Just go to our webpage, namitn.org. namitn.org. At the bottom of the page, there's a button that says e-news. Click on that, or go to the NAMI Tennessee Facebook page, follow that, and you'll get information that way as well. Mary-Linden, any last words?
No, I just really appreciate you inviting me on. We have a lot going on at TAADAS. We're always happy to share, and we are happy to be part of the coalition and share those experiences as well. Thank you.
You could have talked more because the music hasn't started.
Okay. Well, you didn't cue me about that, Jeff. Well, let me
the last
just
words
say.
usually have gone a little longer, but I can fake it. It's okay. Do you have more last words?
Oh, more last words. Well, I've been a part of the coalition for many years before I was even a part of TAADAS, and I just know that it's an amazing and energizing event. I look forward to seeing many, newbies and oldies but goodies there, because I think it's an inspiring event, and it really gets people back every year.
Mm-hmm. Well, thank you, and I'm going to end with this. Don't be afraid to talk to your legislator. They are there to serve you. They work for you, and they'd like to stay in office. And people think, well, I don't give a lot of money. Those that don't give a lot of money may think I don't give a lot of money. My voice doesn't matter. If you take the time to visit your legislator, and you can do it down the hill, or you can do it in your home community when they're back in the district, and say, this issue is important to me. When they hear that from enough people, then that issue becomes important to them as well. So it's not scary. It's not intimidating. We do offer training from time to time. We did it last night to help you to share your story. But really all you have to say is, this is my name. I live right here in this district. And here's an issue that's important to me. I would appreciate if you would support it. And
excellent point. Your legislators are really your neighbors. They live in your communities, and they really want to get to know you and get your input.
Thanks for joining us today for the
Thank
NAMI
you,
Radio
and
Hour,
see you next
exploring
week.
the world of mental illness and its impact on the family, society, and the individual. This broadcast comes your way live from the studios of WRFN Radio Free Nashville Pasquo each Wednesday at 10 a.m. Central Time. If you missed the show today or would like to hear the archives, link to Podomatic.com and search for the NAMI Radio Hour. Again, that's Podomatic.com and search for the NAMI Radio Hour. You can also keep up to date with the show's upcoming guests on the NAMI Tennessee Facebook page. The NAMI Radio Hour is a production of NAMI Tennessee. To contact the show, email to info@namitn.org or call 1-800-467-3589. That's 800-467-3589. We'll see you next week right here for another broadcast of the NAMI Radio Hour. Until then, remember, you are not alone, and don't get stuck in the trials of life. Keep moving on.